the more we learn about, preventative cardiology and trying to help folks and patients stay healthy, we have gotten a lot more aggressive than how we were in the past, for goals and particularly bad cholesterol. My name is Dr. Torabi. I'm an interventional cardiologist at Franciscan Physician Network, and I'm at the Crown Point and Munster campuses. We just had our big conference from the American College of Cardiology, and I think for a lot of patients, I don't want to give the impression that because of this big conference now that everybody needs to be on a statin. That's certainly not true, but I think that the more we learn about preventative cardiology and trying to help folks and patients stay healthy, we have gotten a lot more aggressive than how we were in the past, for goals and particularly bad cholesterol. That's something that we've been targeting for a very, very long time. And, I think for patients out there that want to know if they're doing a good job, and unfortunately these days, we have a lot of the labs available for patients to review on their own. And really the way they can tell if a lab is good or bad is the lab will flag these numbers as red or not red. And for a lot of our patients that have basically coronary artery disease or heart blockages, unfortunately you can't really rely on that number being red or not red. These days for patients that have had a history of open heart surgery, or they've had prior stents in their heart, or they have a lot of other risk factors, they had a prior stroke, we used to be targeting a bad cholesterol that's known as the LDL of less than 70, and now with a lot of the latest guidelines, we're really recommending we got to shoot for less than 55. And that's just for what we call secondary prevention. That means we're trying to protect you from having another event. We don't want you to have another heart attack. We don't want you to have another stroke. We're trying to keep you as safe as we can. And for patients that have not had a prior event before, let's say they've never had a heart attack, we have a lot of these patients that will go now for the CT promotional heart scans. They might just get a calcium score that's elevated. And for patients that have an elevated calcium score, if it's more than 0, now we're shooting for a bad cholesterol less than, the LDL less than 70. So that used to be the cutoff for the patients that have had a stent. So I think for any patient that is just very interested in prevention, and we take a lot of pride in this. I do particularly. And as much as I do work in the cath lab to take care of patients and help them feel better, I take much more pride in keeping them out of the cath lab. And how do we do that? That's with either this primary prevention or secondary prevention. That's just getting a little more aggressive with the the cholesterol cutoffs. But I like to do shared decision making. I don't want to just be the doctor that just says that this is the goal and the only way to do it is with medication. I let patients give it a shot on their own. If they're honest with me and genuine, and they say, hey, you know what, my diet could be better, or I've always wanted to try the Mediterranean diet, then we have fun about it in the office. We say, all right, let's pretend like you're living in Greece. The weather's getting nice. Let's get the olive oil, the almonds, the plant-based protein, the cutting down on the red meats, and let's try to see what we can do. And if they try that and they see some improvement, then great. But it just is very important that we follow up on that. We don't just wait until next year. We want to just see if it made an impact. And if it hasn't, then I really think that that's where you really need to have that discussion and consider a statin. And I will say that for a lot of our health enthusiast patients, just be very careful with what you find online, or even with AI for that matter. Just it's not just Dr. Google anymore. I think that it's very easy to get some misinformation from online resources where all of a sudden you think that the statin cholesterol medicine is dangerous, and it's really not the case. I think that every patient is very different, and you have to kind of tailor the treatment to the patient. The cutoff now has gotten a little bit earlier with the newest guidelines, so we're in April of 2026, and I think a lot of in the past we were probably waiting until patients were in their 40s to start screening for diabetes and high cholesterol. I will say that for a patient that was seeing their pediatrician and now they're going to see a primary care doctor as an adult for the first time, I think it's very reasonable to have a one-time cholesterol check as a very young adult. I'm not saying that this lab needs to be checked, every year, but just for some sort of baseline, just to sort of kind of check and make sure everything's all right. We have not in everybody, but certainly in younger patients that have a family history of high cholesterol, there is a disease called familial hyperlipidemia, and if you have an 18-year-old that has an astronomically high bad cholesterol, it's very important to know that really early on, because that's something that could be treated, and when treated correctly, is very important for prevention. I think that if 40 was the new cutoff originally for screening for diabetes and cholesterol, I really feel that 30 is sort of becoming the new 40. But I'd say that these are sort of the guidelines that are just kind of coming out, and I think that while the thresholds for treatment have sort of changed as time has gone on, I really recommend patients to sort of lean into their primary care provider and kind of take their advice. So if they're recommending to get the routine labs for new baseline, I think that's a really important thing to do. Yes, they do, because we may have a different target or a goal on the bad cholesterol, particularly in diabetic patients. Now, I will say with a diabetic patient, which makes them a little more unique compared to everyone else, is that your hemoglobin A1C, that's your average blood sugar for the last 3 months. If that is very, very elevated, that's going to also increase your bad cholesterol, the LDL. And a lot of times what we'll see in these patients, that if you get your A1C for your diabetes under better control, then your LDL will also come down as well. So I think it's important to always not get too reactive to a number, let's say the bad cholesterol, the LDL, but to, correlate that with the blood sugar and the hemoglobin A1C. And, certainly for patients that, have diabetes, and if they have an elevated 10-year risk score, we call that the ASCVD risk calculator, and that's from the American College of Cardiology, looking for atherosclerotic disease. Again, this is for patients that don't have a history of any heart disease. We put in different numbers like your age and your blood pressure and your cholesterol tests, and we're able to generate what is a patient's 10-year risk of having a heart attack or a stroke. And we have cutoffs for what is considered low risk and intermediate risk and high risk, and kind of using this as a gauge for how aggressive we need to be for now a lot of diabetics, we're really shooting for like a bad cholesterol less than 70. But again, I would definitely recommend that when it comes to your cholesterol goal and what you're trying to achieve, definitely talk with your healthcare provider and make sure that you're on the same page and that everyone has that same goal.